Welcome to this cardiac registry cast about normal heart anatomy. This is a waxed human heart specimen that's been fixed in a distended state so that we can see the three-dimensional structure of the heart. We're looking at the heart from the front. This is the anterior wall here. The diaphragmatic surface is here. This would rest on the diaphragm. The acute angle is in the front, and the obtuse angle is here posteriorly around the left ventricle. The apex of the heart is to the left of the subject, and the base with the atria is to the right. Features on the external surface of the heart include the superior vena cava and the inferior vena cava, which drain into the right atrium. Also, the coronary sinus here in the left posterior AV groove drains in to the right atrium as well through the ostium of the coronary sinus. The pulmonary veins, the right veins seen here, connect to the left atrium. The right pulmonary veins are adjacent to the interatrial septum. This heart specimen has a right superior vena cava here, draining into the right atrium, along with the inferior vena cava, as well as a persistent left superior vena cava here that drains into the coronary sinus. The pulmonary veins connect to the left atrium between the right and left superior vena cava, because the common pulmonary vein enters the left atrial chamber between the two horns of sinus venosus in the embryo. The left superior vena cava represents the left horn of sinus venosus, and the right superior vena cava and inferior vena cava, the right horn. So the pulmonary veins end up here in between the two superior vena cavae when they're both present. Here we see the right pulmonary veins, again adjacent to the atrial septum, and the left pulmonary veins entering here on the left side. The arteries, the pulmonary artery here anterior and to the left, and the aorta here posterior and to the right, arise also from the base of the heart, close to and just in front of the two atria. The pulmonary artery is aligned with the right ventricle here in the front, while the aorta is aligned with the left ventricle here from the back. The atrial appendages, the left atrial appendage here and the right atrial appendage here, are on either side of the vascular pedicle, or the great arteries here in between them. The right atrial appendage is large and has a broad connection with the body of the right atrium. In contrast, the left atrial appendage is quite small and finger-like and has a small orifice here into the left atrium. The sinoatrial node is in the crista terminalis, which is seen from the outside as the sulcus terminalis between the atrial appendage in the front and the superior vena cava posterior and rightward. The sinoatrial node then passes around anterior and lateral to the superior vena cava in the crista terminalis. This heart specimen has been injected to show the coronary arteries. Yellow plastic was injected into the right coronary system. Here we see the right coronary artery arising right and anterior from the aortic root. The first branch is the sinoatrial node artery, which passes here toward the sulcus terminalis between the atrial appendage and the superior vena cava. Next, the right coronary artery gives rise to several preventricular branches and an acute marginal branch that runs down the acute margin of the heart. The right coronary continues around the posterior and inferior aspect of the heart to give off the posterior descending coronary artery. In this heart, the right coronary continued past the midline and supplied part of the posterior aspect of the left ventricle. This is a rather common variant. At about this point, in approximately 90% of people, the right coronary artery gives off the atrioventricular node artery. And we can see this here deep inside the right atrium as a small yellow vessel here going up toward the atrioventricular node, which will be in about this area in the atrium. The left coronary artery in this heart is shown in red. It arises behind the pulmonary trunk from the left posterior aspect of the aorta and bifurcates behind and under the left atrial appendage. The anterior descending artery passes down the anterior interventricular groove all the way to the apex of the heart, and then anastomoses with the posterior descending that arises from the right coronary artery. This anterior descending artery gives rise to a number of diagonal branches which then pass across the free wall of the left ventricle. The other branch of the left main coronary is the circumflex artery, the left circumflex artery, which passes here in the left AV groove toward the posterior aspect of the heart. There is a large obtuse marginal branch that arises from this artery here and passes down the obtuse margin of the left ventricle. The cardiac veins in this structure are seen in blue. These are mostly associated with the left ventricle. Here's the great cardiac vein, which parallels the anterior interventricular artery and passes down the anterior interventricular groove under the atrial appendage into the left atrioventricular groove. It then joins the middle cardiac vein here to form the beginning of the coronary sinus. There's also a posterior cardiac vein and some intermediate cardiac veins that drain into the coronary sinus as well. We can see small dots on the inside of the right atrium. These are Thebesian veins that drain directly back into the right atrium as well as into the right ventricle. Opening the right atrium shows some of the features that are characteristic and in fact diagnostic of a morphologically right atrium. Probably the most reliable marker for a right atrium is the presence of the ostium of coronary sinus. Here we see coronary sinus running in the posterior AV groove and then joining the right atrium between the foramen ovale or fossa ovalis and the tricuspid annulus. The ostium of coronary sinus typically has a small valve called the Thebesian valve in front of it. The Thebesian valve joins the Eustachian valve, which is the valve of the inferior vena cava. Another very characteristic feature of a right atrium is the presence of pectinate muscles outside the atrial appendage, here in the body of the atrium at the vestibule of the tricuspid valve. The appendage is here superiorly, and you can see that the pectinate muscles extend all out into the body of the atrium. Typically, the pectinate muscles terminate in a crest or muscle bundle called the crista terminalis, which is around the orifice of the superior vena cava here. This is superior vena cava. And the crista terminalis runs in the sulcus terminalis between the superior vena cava and the right atrium, and then out on the lateral wall of the atrium below the superior vena cava. And this is where the sinoatrial node can be found. The atrial septum on the right atrial side is characterized by septum secundum, or the superior limbic band. This forms the upper border of the fossa ovalis or foramen ovale, while septum primum, seen here, forms the floor of the fossa. If the fossa is open, one can advance a probe between septum secundum and septum primum into the left atrium. We can identify the location of the atrioventricular node in the right atrium as well. The eustachian ridge here extending up from the inferior vena cava along the eustachian valve up toward the membranous septum, and the tricuspid annulus form two legs of a triangle called the triangle of Koch. The base of the triangle is through the base of the coronary sinus. And this triangle, formed by the eustachian ridge on the right, the tricuspid annulus on the left, marks the location of the AV node at its apex. This is just below the membranous septum. The tricuspid valve is seen here to the right, the medial leaflet, and the anterior or superior leaflet. This is the commissure between those two leaflets, and just beneath this commissure is where one can find the membranous septum. The AV node and penetrating bundle then penetrate just below the membranous septum on the muscular crest of the interventricular septum to reach the ventricle. The right atrium is typically organized so that, if we use the fossa ovalis as a reference point, the ostium of coronary sinus is to the left of the fossa ovalis, and the superior vena cava is above and to the right, and the inferior vena cava just below the fossa ovalis. The right atrium in the normal heart is aligned with and connected to the right ventricle by the tricuspid valve and the right AV junction. If we look at the right AV junction carefully, one can see ventricular muscle here below and atrial muscle here above. And the two are separated by fibrofatty sulcus tissue that has grown in from the epicardium on the outside and has made contact with the fibrous annulus of the tricuspid valve. The leaflet of the tricuspid valve ends here in that fibrous annulus. And the combination of these two non-muscle tissues, the fibrofatty tissue from the epicardium and the fibrous tissue from the annulus of the tricuspid valve, separate and insulate atrial and ventricular myocardium. If there is muscle-to-muscle contact across the AV junction, except at the AV penetrating bundle, then that constitutes an accessory pathway and makes patients susceptible to developing arrhythmias. We also see the right coronary artery running in the right AV groove here as well. The right ventricle also has characteristic features. One is the coarse trabeculations that we see around the right ventricle on the free wall as well as on the septum. The right ventricle is more or less trapezoidal in shape, with one edge of the trapezoid formed by the tricuspid annulus, the base by the acute margin of the heart here, another leg by the apex and anterior wall of the right ventricle, and the top of the trapezoid by the base of the pulmonary valve. The muscle bundles that we typically identify within the right ventricle include the septal band, which passes down the interventricular septum. At the basal end, we see a typical reverse C-shaped structure here, the so-called Y of septal band. The papillary muscle of the conus, or the medial papillary muscle of the tricuspid valve, is associated with the inferior ramus or inferior limb of the Y, and the superior limb is directed toward the pulmonary valve. At its apical end, the moderator band originates from the septal band and passes to the anterior free wall, giving off the anterior papillary muscle of the tricuspid valve. A very characteristic feature of the right ventricle is the fact that the septal leaflet of the tricuspid valve, seen here, has direct insertions onto the interventricular septum with very little space between the medial or septal tricuspid leaflet and the interventricular septum. The right ventricle typically has a body or sinus portion below, which receives all of the insertions of the tricuspid valve, and an infundibulum or outlet or conus above, typically above the papillary muscle of the conus, that supports the pulmonary valve. The tricuspid valve has, as the name would indicate, usually three leaflets: a medial leaflet that we've already seen with attachments onto the interventricular septum, an inferior or posterior leaflet here, associated with the inferior aspect of the free wall, and an anterior or superior leaflet here. The leaflets are demarcated by commissures, and commissures typically occur at papillary muscles. So the commissure here between the septal leaflet of the tricuspid valve and the anterior leaflet is at the medial papillary muscle or the papillary muscle of the conus. The commissure between the inferior or posterior leaflet and the superior or anterior leaflet is here at the anterior papillary muscle. And the third commissure between the posterior or inferior leaflet and the medial or septal leaflet is here at the posterior papillary muscle. In this case, there are a couple of heads associated with the posterior papillary muscle. The number of heads can be variable. We think of the ventricle as having chirality or handedness. One could identify, for example, a right hand, even if it were severed from the body, simply by the organization of the hand. And the same thing with a right-handed or D-looped or soletus right ventricle. This is an example of a D-loop or soletus ventricle, and it can best be described using the hand rule with the right hand. The convention is to place one's thumb into the tricuspid valve, fingers in the outflow tract, and palm against the interventricular septum. And this can only be done with a right hand. It's not possible to do that with a left hand. So this is a right-handed or soletus or D-looped right ventricle. This is what's present in the normal heart. The interventricular septum can be seen very well from the right ventricle, and this is the usual orientation, either from the right ventricle or through the tricuspid valve, that the surgeon would use to inspect the septum as well. Most of the septum is the muscular trabecular septum. The membranous septum, as we said, is here behind the septal leaflet of the tricuspid valve, just at the commissure between the septal and anterior leaflets. So it's here. The inlet muscular septum is the part of the muscular septum adjacent to the tricuspid annulus and behind the septal leaflet of the tricuspid valve all the way down to the diaphragmatic wall. This is the septum that's typically missing in a common AV canal defect, so this is often called the AV canal septum, even though it isn't AV myocardium that makes up this part of the septum. The outlet septum is here in the Y of septal band. This muscular ridge inserts into the Y and divides the outflow channel into an anterior pulmonary channel and a posterior aortic channel that goes behind the infundibular septum to reach the aorta. In the normal heart, the pulmonary artery arises from the right ventricle above conal muscle that separates the pulmonary valve from the tricuspid valve below. The pulmonary valve has 3 leaflets that are approximately semicircular in shape, so it's called a semilunar or half-moon valve. That's because of the shape of the individual leaflets. The valve has commissures between the leaflets where the edges come together and where the valve can separate so that it can open and close. The tops of the commissures form the sinotubular junction, or the junction between the sinuses of Valsalva behind the bellies of the leaflets here and the tubular portion of the pulmonary trunk. The pulmonary trunk is typically quite short, only a centimeter or so in this heart, and divides into a right and left pulmonary artery at the pulmonary bifurcation. We've now turned the specimen over and are viewing it from the back to see the left atrium and left ventricle. Because we're viewing the heart from the back, this is now the right side of the patient and this is the left side of the patient. The left atrium is quite distinct from the right, in part because it has completely smooth walls. There's little or no trabeculation within the body of the left atrium. The pectinate muscles are confined to the atrial appendage, which we see here opened. The left atrial appendage is small and somewhat finger-like, and one can see the pectinate muscles within the appendage. The ostium of the appendage, or its junction with the body of the left atrium, is quite small, unlike the right atrium. The characteristic feature on the septum of the left atrium is the presence of septum primum, which is a hammock-like structure that we see here with insertions on each end and a small separation between septum primum and septum secundum. This is actually a closed fossa ovalis. One can't probe through into the right atrium. The pulmonary veins enter the back of the atrium here and here. The organization of the left atrium, again using the fossa ovalis as a reference point, has the mitral valve to the left of the fossa ovalis and the appendage superior and somewhat leftward. The pulmonary veins enter the posterior and rightward aspect for the right pulmonary veins, and the posterior and more leftward aspect for the left pulmonary veins. In the soletus heart, the right pulmonary veins are adjacent to the interatrial septum, and the left pulmonary veins are away from the septum and closer to the appendage. In the normal heart, the left atrium is aligned with the left ventricle and connected to the left ventricle by the left AV junction and the mitral valve. Just as we saw for the right AV junction, there is fibrofatty sulcus tissue that separates the left ventricular muscle below from the atrial muscle above. This tissue joins the fibrous annulus of the mitral valve, just as we saw it joining the fibrous annulus of the tricuspid valve on the other side of the heart. Here, the thickness of this tissue is a little greater, possibly because of the increased wall thickness of the left ventricle. The mitral valve has a medial or septal leaflet or anterior leaflet in the normal heart, as well as a mural or posterior or lateral leaflet here against the free wall. The left ventricle is characterized by a smooth basal septal surface here with fine apical tuberculations, unlike the very coarse muscle bundles that we saw in the right ventricle. The medial or septal leaflet of the mitral valve has no insertions onto the interventricular septum, but instead has multiple chordal attachments to a pair of free wall papillary muscles, the posteromedial muscle group near the inferior interventricular septum and the anterolateral group on the anterior or superior part of the free wall of the left ventricle. Both the medial or septal leaflet and the posterior or mural leaflet have attachments to both of the papillary muscle groups. The papillary muscles tend to be somewhat U-shaped or horseshoe-shaped, with often 2 or 3 heads coming from the same base. Occasionally there is a medial papillary muscle group in between the 2 primary papillary muscle groups joining the posterior or mural leaflet. The shape of the left ventricle is more bullet-like or ellipsoidal. This seems to facilitate contraction. The septum in the left ventricle has mostly a muscular interventricular septal component like we saw in the right ventricle. The membranous septum is here seen from the left ventricle just below the commissure between the right coronary and non-coronary leaflets of the aortic valve. Here's the commissure with the fibrous trigone in it, and just below that is the membranous interventricular septum. Anterior or superior below the right coronary leaflet of the aortic valve is the outlet or infundibular septum. This is the area that's typically missing in a subpulmonary or doubly committed subarterial defect, often associated with aortic insufficiency. Just as we noted that the right ventricle is chiral or handed, so is the left ventricle. And in fact, it has the opposite handedness of the right ventricle. If we use our hand rule again, a thumb in the mitral valve, fingers out the outflow, and palm against the septum, you can see that this soletus or D-looped left ventricle requires a left hand. I can only do that with my left hand. I can't use a right hand to describe this left ventricle. So just as a D-looped or soletus right ventricle is described with a right hand, a D-loop or soletus left ventricle is described with a left hand. So it's actually quite easy to remember. The normal right ventricle is right-handed, the normal left ventricle is left-handed. Another characteristic feature of the left ventricle is fibrous continuity between the medial leaflet of the mitral valve and the aortic valve. The continuity is between most or all of the non-coronary leaflet of the aortic valve and about half of the left coronary leaflet of the aortic valve. The left ventricle ejects into, is aligned with the aorta, and is connected to the aorta by this aortic mitral fibrous continuity. There's no free wall infundibular component under the aortic valve as we saw under the pulmonary valve. Again, the semilunar valve leaflets are half moon shaped, as the name indicates, and have a body or belly of the leaflet here that's attached along its free edge, a commissure between adjacent leaflets of the valve that inserts up to the sinotubular junction, the junction between the sinus of Valsalva and the tubular portion of the ascending aorta. The coronary arteries usually arise around the sinotubular junction or in the sinus of Valsalva. Here's the origin of the right coronary artery, just below the sinotubular junction in the right coronary sinus. The left coronary is here, arising from the left coronary sinus, in this case just above the sinotubular junction. This is not a typical location for the origin of a coronary ostium. The aorta continues as the ascending aorta and then the aortic arch, which gives rise to brachiocephalic arteries that supply the head and shoulders, and then continues as the descending aorta. The great arteries are solitous, normally related great arteries in this heart, and that means that the aorta is here, posterior and rightward, while the pulmonary artery is here, anterior and leftward. Here we see the pulmonary valve on the inside, and the aortic valve is here near the origin of the right coronary artery. So these great arteries have a posterior rightward aorta and an anterior leftward pulmonary artery. And further, the pulmonary artery bifurcation into the right and left branches is here on the left side of the ascending aorta. So we have the bifurcation to the left of the ascending aorta. So these are solitous, normally related great arteries. To illustrate the concept of chirality or handedness or organization of the heart, this is a heart from a patient who had situs inversus totalis, or complete inversion of the viscera. Associated with that, the heart was in dextrocardia, the apex of the heart pointed to the right, and the heart was in the right chest, as you would expect for someone whose viscera were completely inverted, or left-right mirror imagery. So we're now looking at the heart from the front. This is the base, which was to the patient's left, and this is the apex, which was to the patient's right. The diaphragmatic surface is here, and the outflow is here. Here we see the right atrial appendage in the morphologically right atrium, which is now left-sided. Here we see the typical pectinate muscle architecture of a right atrium, extending right around the vestibule of the tricuspid valve here. In addition, this is the ostium of coronary sinus coming into the floor of this right atrium. And here we see septum secundum as the prominent feature of the interatrial septum here at the superior border of the fossa ovalis, with septum primum forming the floor of the fossa. Notice in this heart that superior vena cava exits superiorly, but to the patient's left rather than to the patient's right, as we saw in the solitus or normal heart. The inferior vena cava is here below the fossa ovalis, just as in the soletus right atrium. Note that the organization here is just opposite of what we saw before in the soletus atrium. Now, using again the fossa as our point of reference, the coronary sinus ostium is here to the patient's right, as is the tricuspid orifice. Whereas before we saw in the normal heart that the coronary sinus and the tricuspid orifice were to the patient's left with respect to the fossa ovalis. So this right atrium is organized exactly in mirror imagery or left-right inversion compared to what we saw before in the soletus heart. Similarly, the right ventricle is organized in just the opposite way. We see that this has all the characteristic features of a right ventricle with tricuspid valve, inflow and outflow, coarse trabeculations, muscle bundles that are characteristic of the ventricle, like the septal band here, with the Y of septal band, the inferior ramus marked by the papillary muscle of the conus, the superior ramus directed toward the pulmonary valve, and the takeoff of the moderator band from the apical end of the septal band. But notice that in this case, instead of being able to use a right hand to describe this right ventricle, it requires a left hand with my thumb in the tricuspid valve, fingers out the outflow, and palm against the septum. I can only do that with a left hand. I can't do it with a right hand. So this is an inverted or L-looped or left-handed right ventricle. This is exactly the mirror image or the opposite of what we saw before in the soletus heart. Now, if we turn the specimen again to the back so that we're looking from the back of the patient, so that this becomes the right side of the patient and this the left, we see again a typical left atrium, but that it's right-sided compared to the right atrium, has smooth walls, typical left atrial appendage, and septum primum here on the septal surface, as we saw for the other soletus left atrium. But notice now, again, this atrium is inverted. Using the fossa as our point of reference, now the mitral valve is to the right of the fossa instead of to the left. And the appendage is superior and rightward instead of superior and leftward, as we saw in the other heart. And now it's the left pulmonary veins that are adjacent to the septum rather than the right pulmonary veins. So the left atrium is organized exactly oppositely, or in mirror image, of what we saw in the soletus heart. Similarly with the left ventricle, this left ventricle is a mirror image or an inverted ventricle compared to the soletus D-looped ventricle that we saw before. This is an L-looped or inverted left ventricle. Again, this is the patient's right and this is the patient's left because we're looking from the back at the left ventricle, looking forward toward the interventricular septum. And we can see all the characteristic features, the smooth septal surface, fine apical trabeculations, free wall papillary muscles, the mitral valve with attachments only to the papillary muscles and not to the interventricular septum, and aortic to mitral fibrous continuity here in the outflow tract. Now, describing this ventricle requires a right hand because it's inverted or L-looped. If we put a thumb in the mitral valve, finger out the aortic outflow, and palm against the septum, I can only do this with a right hand. I can't use a left hand to do it. This is an inverted or L-looped left ventricle, just the opposite of the soletus or D-looped ventricle that we saw in the other heart. Again, in contrast to the soletus heart, the great arteries are also inverted. They're inverted, normally related great arteries. They're just the mirror image or the opposite of what we saw in the soletus heart. For example, here's the aorta, the aortic valve, is now posterior and leftward, whereas the pulmonary artery is here, anterior and rightward in this heart. The aorta, ascending aorta and arch come up on the left side and go to the right, while the pulmonary bifurcation into a left and right pulmonary artery is here to the right of the ascending aorta instead of the left, as we saw in soletus normally related great arteries. In addition, in inverted normally related great arteries, it's the left pulmonary artery that passes behind the ascending aorta instead of the right pulmonary artery.